Hello, everyone, and welcome to our webinar titled Go Paperless and Get Paid, Industry Support of Provider EFT and ERA Adoption, with guest speakers from NACHA and WEDI. My name is Kira Newman, and I am the Associate for Education and Outreach here at CAQH Core. We're happy to have you today. So just to start, I would like to mention a few logistical items. You will be able to download a copy of today's presentation from our website at CAQH.org tomorrow. Also, a copy of the slides and the webinar recording will be emailed to you in the next day or so. We will save time at the end of today's program to respond to your questions, but I encourage you to submit your questions at any time during the webinar by typing them into the questions panel on your dashboard. So our agenda for today, we will start off with an overview of the Phase 3 CAQH Core operating rules, followed by presentations on the NACHA electronic healthcare payment update, as well as the WEDI EFT ERA adoption resources and best practices. And we will end again with the question and answer portion. So let's get started with our first presenter, CAQH Core Director, Robert Bowman. Bob?
Great. Thank you, Hira. We do want to provide just a quick update on who CAQH Core is and our role in drafting operating rules for these particular transactions. And beginning on the next slide, you'll see that we really are a mission and vision driven organization. Our vision really is to be the industry-wide facilitator, bringing diverse groups of stakeholders together. You can see some of them there on the screen, but all of them working together to derive specific benefits from the adoption of electronic transactions. And through the use of the standards and the operating rules, looking and aligning both administrative and clinical activities between the different stakeholders to drive efficiencies, reduce costs, and bring those wins to the industry. It is important to know that we are designated by the Secretary of HHS to be the national author for 3 sets of operating rules that are mandated through the ACA regulation. Moving on to the next slide, part of our drive to ensure that we are bringing value to the industry is ensuring that we have everyone at the table. And we like to refer to ourselves as kind of like a Switzerland. Everyone comes to CAQH Core, they participate, and they help draft the operating rules and requirements that every other organization will be responsible for. So we have over 130 participating organizations. We've developed 4 different sets or phases of operating rules to date, and we're working on our 5th right now. 3 of them have been mandated for adoption by HHS through regulation. And we've also included, part of our process is to include certification process or a program for those 4 different stakeholder types: health plans, providers, clearinghouses, and software vendors, to ensure that their systems and applications are in conformance and in compliance with the operating rules. And to date, we've issued over 330 different core certification seals to those entities who have completed the certification process. Again, that certification process is voluntary. On the next slide, you'll see that the areas where we do have sets of operating rules in place today include our phase 1 and 2, which are for health plan eligibility and claim status transactions. This helps improve patient registration process, it reduces claim denials, it decreases duplicate claim submissions, and also reduces the misidentifications of patients and mistaken denials, because you are verifying eligibility when the patient presents. You're able to check claim status transactions anytime prior to and even after you've received the remittance advice to ensure that you understand exactly where the claim's at in that adjudication process. Most important for today is our phase 3 set of operating rules. That includes operating rules for the EFT transaction as well as the healthcare payment and remittance advice transaction. And these specific transactions, we'll hear much more about this later in the presentation today, they help improve the cash flow for expediting payment and remittance advice reconciliation. It does eliminate the need for manual rekeying if you have a system or application that can allow you to auto-post the remittance advice data. It also helps you, increases really the ability for you to do target payment issue follow-up. And what we mean by that is you'll be able to understand exactly the reason why a specific claim or claim line has been adjusted or denied or paid, and exactly understand what you need to do as a provider or someone who works in the billing office exactly what to do next. Do you have to rebuild? Do you have to submit some piece of data? Do you have to submit an attachment? What are the requirements by the health plan? Hopefully those are more easy to understand from having a consistent set of information back to you. And lastly, our phase 4 includes the rest of the HIPAA transactions, including claims, referrals, prior authorizations, enrollment, disenrollment, premium payments, as well as looking forward to attachments. Those are coming. I will let you know more about that a little bit later. But all of these are really to help set the foundation for more enhanced operating rules in the future by ensuring that the train tracks are laid to ensure, again, infrastructure allows for the conduct of the transactions, knowing that the expectations, roles, and responsibilities of the trading partners, that information is now available in our phase 4 rule set. Moving into the specific topic for today on the next slide related to the electronic transactions for EFT and ERA for the claim payment as well as the remittance device transaction. The CAQH index has tracked these transactions for a number of years. And for just over the 3 years you see here on our table, the claim payment transaction has increased some. It's a little more, and the reason for this, I think, is that there's been some hesitancy from many in the provider community to move to a claim payment. They're used to receiving their claim payments via paper check today, but we have seen this uptick over the last couple of years. The remittance devices had more substantive increase from 51% to 55% in the 2 years tracked, the year tracked for the CAQH index. So a 4% increase year over year for the adoption of the ERA transaction. And I think you'll see that when we publish our next iteration of the CAQH index later next month, you'll see the numbers have increased again. Also, some of them substantively for some of the transactions, because the providers have really seen the wins in using electronic transactions, particularly for claim payment and remittance advice transactions. On the next slide, you'll see the specific rule requirements. We won't go into a lot of detail here, but just so you understand that there are specific standards that have been named and required by HIPAA and by regulation to be used. That includes the NACHA ACH CCD Plus Addenda record, along with the X12 TR3 TRN segment for the EFT standard, and the ERA and EFT operating rules are also required to be adopted by all HIPAA-covered entities. Again, it will be upon the provider if they wish to adopt and use those standards. So it is still not required for providers, but it's by their desire to move to a more electronic process and allow for that auto posting of the remittance information and the payment information. So the rules try to facilitate the adoption of these transactions for the provider. That includes our set of infrastructure rules. So Rule 350, it sets up a companion guide requirements, connectivity, and requires acknowledgement. The reassociation rule allows for specific data to be included in the EFT and the ERA so that providers can link those two transactions together when they receive them from different sources, as well as the enrollment data set rule, which allows for a set of EFT and ERA enrollment data that health plans will accept electronically for processing to ensure providers can enroll to receive these transactions. And last but not least, there is a data content rule specific to the use of the claim adjustment reason codes and the remittance advice for mark codes. So these specific code values within the 835 transaction that allows you to understand exactly why a particular claim or claim line has been adjusted, paid, or denied. So that messaging to the provider to understand why something was adjusted is really important in auto posting and then working your denial. On the next slide, we highlight some of the resources that CAQH has published, and you'll see some later resources too from other organizations on today's call. But we want to ensure that providers have exactly what they need to ensure that they can adopt these transactions successfully. And so beginning with our first one, providers can do an assessment of their systems, who they have as a vendor, what systems, what applications they use. And again, it could be anything from a provider portal to homegrown system to your manual process when you receive a paper check. you can look and see exactly what you need to do, how to convert those systems and processes and agreements that you have to ensure that they can meet and conduct the CCD plus transaction as well as the 835 transaction. Next, in step number 2, you can understand that health plans agreements and options for payments. You need to check with your health plan to see how they offer the EFT transaction as well as the ERA transaction. So that's a conversation that you can have with your health plan that you're conducting business with. And we do have some draft letters that you can use as a basis for that conversation. So those are also available for free on our website. And lastly, we do have, as I mentioned earlier, a certification component to the core operating rules for Phase 3 specifically, for all of them, but also for Phase 3. You can check and see which clearinghouses, which vendors, which health plans have voluntarily gone through the process of becoming core certified, and those systems will meet those requirements in ensuring that you can receive the reassociation data, that you can ensure that you're receiving the messages, the CARCs and the RARCs, as I mentioned earlier, those messages back to the provider in a consistent way. So it validates and verifies that those stakeholders have gone that extra step in becoming core certified. On the next slide, you'll see that just a little bit more information related to our core code combinations maintenance process. As I mentioned, the CARCs and the RARCs, they do go through an update process 3 times per year. So CAQH Core also goes through an update process to ensure that our core code combinations are up to date and are consistent with the new set of codes that are published every 3 times per year. So we do that process, and we use the feedback that we have from the industry to do that. Our core participants lead that task group. But we also ensure that we listen to the market as well, because we do have on our next slide just some of the work that the task group is doing. They do conduct that compliance-based review 3 times per year, as I mentioned. But listening to the broader market, the market-based review goes out to anyone who needs to look at the codes can complete a market-based review. And that market-based review is just closed on March 2nd. We had a number of submissions that the task group is going to review. There were beyond just compliance-based reviews, but the market has seen a need to change the code combinations. So the task group is working on what those adjustments will be. Again, we have a very specific set number of scenarios. We have 4 scenarios with specific code combinations in each one to ensure that the providers are getting the right message and it's a clear message so that they can take the appropriate actions. If there's missing information, if there's missing data on the claim, if there's missing attachments, if there's something to deal with the benefit not being separately billable, is it a roll-up charge, or is it a breakout charge, or is it a billed service not covered? Is this particular service that the provider rendered is not actually covered by this particular policy or plan that the member is under? So again, we look at these very specific messages for the providers to ensure they know what steps to take next. So again, I know I just shared a lot with you, but I do want to share or move on to our next guest speaker, which is Priscilla Holland, who's the Senior Director of Healthcare Payments from NACHA. So Priscilla, I'll hand the mic over to you.
Great. Thanks, Bob. I appreciate that. Let's go on to the next slide, please. The next slide is basically an overview of who NACHA is. If you have not heard of NACHA, we are actually the private sector rulemaking organization for the ACH network. We don't process payments. We write the rules. We are actually a nonprofit trade association, and we are responsible for the rules and for the standards used in the in formats in the ACH network. And NACHA was NACHA's CCD, as Bob mentioned earlier, was identified by NCHS as the healthcare EFT standard. So going on to the next slide, this is a very basic slide, but from the provider's perspective, what are we talking about with regards to the healthcare EFT standard, and where does it fit into the process? And looking at the diagram on the left, what you're looking at is the payment that is sent from the health plan to the provider after the claim has been submitted, after it's been adjudicated. It is a way to automate the process and used in conjunction with the electronic remittance advice is a way for a provider to save a substantial amount of time and, in most cases, money. But the payment goes, if you're looking at the diagram, from number 3, the health plan, it will go through the ACH network, which is down to number 5, to the health plan's financial institution, goes through the ACH network to the provider's financial institution, and then the provider's financial institution will notify the provider that the payment has been received, or you'll see the deposit in the provider's checking account. If you go to the next slide, in looking at the healthcare EFT standard, Bob had mentioned earlier that the NACHA CCD, which is basically our business-to-business type payment, we have different types of codes indicating the different type of payments within NACHA, and CCD refers to a business-to-business payment. It is the CCD plus one addenda record that was identified as the healthcare EFT standard and became effective January 1st of 2014. And what the addenda record is a up to 80 characters of information that can be carried with the payment from the health plan to the provider. And based on the regulation, it must contain the TRN reassociation trace number that is also carried in the 835 electronic remittance advice. So using the TRN reassociation trace number, a provider can auto-reconcile the payment and the remittance advice. And the delivery of the healthcare EFT standard for claims reimbursement payments is mandatory for the health plans. They must be able to deliver it, but it is not mandated to the provider. The provider can request it, but by regulation it is not required for the provider. Now there are some health plans that are including the requirement to move to electronic payments in their contracts. This is allowed by law, and it is something that the health plan and the provider can work out, but it is not prohibited. So it can be included in the provisions. Going to the next slide, what we have is what Bob had discussed earlier, is the mandated healthcare EFT and ERA operating rules. NACHA was worked with CAQH Core in the development of these operating rules, and I wanted to point them out specifically for the data enrollment. It identifies a maximum set of data elements that can be used in the enrollment form. It outlines a flow and a format for paper and electronic collection of the information, and it is required. So it's not something that you can put an enrollment form out on your website and have anything in any order. The purpose of this was to put it in a standardized order to make it easier for the providers as they go from one health plan to a next to enroll in EFT or in ERA. And looking at the 370 rule, one of the key things with regards to this is the elapsed time between the sending of the 835 and the healthcare EFT standard. One of the challenges that had been identified early on with the EFT and the ERA was the time frame between when an EFT was sent or an ERA was sent and then the other document accompanied it. So the operating rule mandates that it is 3 business days before and no later than 3 business days after the effective entry date of the EFT that the ERA must be issued. This also, the 370 rule also requires that the health plan advise the provider that they have to contact their financial institution to request the delivery of the TRN reassociation trace number. This is not something that a bank will generally deliver unless it is requested, and the banks want to talk to the providers about how they want to receive this information. What is the time frame associated with it? Is it electronic? Is it paper-based? How does the provider want to receive that information? So it is important that the providers recognize that they have to talk to their financial institution to get this information delivered so that they can auto-reconcile the transactions. Going to the next slide, NACHA itself has actually incorporated the healthcare operating rules or the healthcare EFT standard into the NACHA operating rules. We wanted to make sure that that our rules aligned, and what we have done is added a specific identifier into the CCD format so that we do know that those payments are claim payments and they are going from the health plan to the provider, and it allows the ACH operators to actually track these and count them so we can, for the first time, have an actual count of the healthcare claim payments that are going through the network. It does mandate that the TRN reassociation trace number be included as the healthcare EFT standard rule does, but it also lets NACHA and the financial institutions make sure that the TRN is formatted correctly within the ACH record. The other important thing with regards to the healthcare operating rules in NACHA is that we have had made a change to the rules that basically says that the provider's bank has to have a secure electronic means to deliver that TRN reassociation number to the provider if the provider requests it. Before, they just had to deliver it. We stepped it up one level and basically said you have to offer or make available a secure electronic option. The provider doesn't have to accept it. They can get a paper remittance if they are interested, but it does have to be available to them. So that was an additional change with the implementation of the healthcare operating rules. Now going to the next slide, this is looking at the volume of healthcare EFT transactions that we've seen flowing through the ACH network. And as Bob indicated, there has been an increase. If you go back and compare the volumes from the ACH network and the CAQH numbers, the numbers are different. The numbers are different because CAQH is working with a specific group of organizations, and they are talking about the claim payments that they have issued. What NACHA is tracking is all of the volume that flows through the network, and you may have multiple claims within an ACH record. So while CAQH is tracking claim payments made, ACH is, the network is actually tracking the payments that are made. So if you look at the two of them, you'll see that there is a difference, but that's where the difference, why we do have a difference. In going to the next slide, we're going to look at what are the value propositions to the providers. And from a provider's perspective, it is really helpful if you have I'm sorry, I just lost the word. If your system, your receivable system in your office has the ability to auto-reconcile your EFT and ERA. If you will receive a healthcare EFT standard, what we're finding in the industry is that health plans are paying these faster than they normally do a paper claim. It does allow the providers to update their receivable system faster and actually be able to provide a patient with an accurate bill sooner, which is they're more likely to pay. It does allow you with the TRN reassociation trace number to reconcile the EFT to the ERA, so you do know which claim is being paid. It helps if you're auto reconciling. It does help reduce posting errors. It reduces your administrative work and in days in accounts receivable. And we'll talk a little bit more about that on the next slide. And it reduces your accounts receivable processing by moving from paper to EFT. And the 2016 CAQH report indicated that the healthcare industry, both the health plans and the providers, could save an estimated $7.87 per claim payment and remittance advice by moving to electronic transactions and auto reconciliation. So looking at the next slide, one of the things that NACHA has done with the resources that we've put together is we went out and talked with a variety of organizations to see to get a value proposition from different size organizations. We looked at a single doctor practice, basically a micro practice that is performance pediatrics. Everything in their office is automated. That helped their office be able to maintain the quality of health care and allows them to continue to reduce their expenses. So you can use it in a micro practice. The other case study we did was looking at a mid-sized provider practice. I think there were 56 physicians associated with this practice in Illinois. They were looking at, they were at 95% receipt of their payments via EFT and 95% via ERA. In using the EFT and ERA and auto reconciling, they doubled the size of their practice in 7 years. They doubled the number, basically doubled the number of claims that they were processing. They did not have to add to staff. They were able to reduce the days in accounts receivable from 25 to 13. So they saw some significant value propositions to their organizations in using EFT and ERA. And then the last case study that we did on the right was with the Hospital Corporation of America and looking at how they, as a major hospital group, implemented the healthcare EFT standard, ERA, and auto reconciliation, and were actually able to reduce their receivables cost by 70%. They were able to do posting of 70 to 75% of their transactions the first day, and they were up to over 95% by day 2 or day 1. Sorry, it was the 70 to 75% on the day they received them. So there are significant value propositions to the providers in doing auto reconciliation and receiving the healthcare EFT standard along with the electronic remittance advice. Now, if you go to the next slide, we're going to see the NACHA resources. NACHA has spent a lot of time looking at ways to help the industry implement the healthcare EFT standard, looking at the value proposition, putting information out there so that you can understand how the ACH network works, what it does as far as the healthcare EFT standard, and this is some of the information that we have available. And Pam's going to talk in a few minutes about the fact that many of us, CAQH, NACHA, WEDI, work together with another organization called HATA, and she has what the acronym means on one of her slides, and we have consolidated resources at that website. So Pam's going to talk about that in a few minutes, but at this point I'm going to turn it back over to Kira, and she has our first polling question.
Thank you, Priscilla. So we're going to go ahead and launch this first polling question. So you can please submit your response on the screen. So our first polling question asks to please indicate the extent to which your organization sends or receives healthcare payments through EFT. So this is the ACH network only. Our options are never, 0% of the time, occasionally, 1 to 35% of the time, sometimes, so it's 36 to 50% of the time, often, 51 to 90% of the time, and always, 91 to 100% of the time. So we're going to leave this poll open for a few more seconds just to make sure everyone has a chance to respond, and then we'll share. Okay, we're going to go ahead and close the poll and share the results. So it looks that our most commonly folks are sending or receiving healthcare payments through EFT very often. So about half of you responded that you're using this 51 to 90% of the time. And then some of you are even doing it more than that, up to 100% of the time, and a very small percentage are not using this transaction at all or very rarely. So for our speakers, especially you, Priscilla, are there any comments or initial thoughts on these polling results?
I'm very happy to see the often and always. It would be interesting to know why the nevers or occasionally haven't moved into accepting it more often. But it's good. It's very good information. Thank you.
Thank you, Priscilla. So for those of you who did select never or occasionally, if there's more information that you're looking for, I'll plug this again. You can always submit questions throughout this webinar in that questions panel. We might be able to get to it by the end of the session. But I'd like to now introduce our next speaker. So we are going to be moving on. Our next speaker is Pam Grose, who is Vice President and Senior Product Manager for PNC Bank's Healthcare Division. Welcome, Pam.
Thank you. Let's go ahead to the next slide, please. And the next one after that. We're just going to skip this disclaimer, and we're going to skip all the blah, blah, blah about me and go on to information about WEDI. WEDI is the Work Group for Electronic Data Interchange, and WEDI is a nonprofit organization focused on the use of healthcare IT to improve healthcare information exchange, with the ultimate goal of enhancing quality of care, improving efficiency, and reducing costs for both payers and providers. WEDI was originally formed in 1991 by the Secretary of Health and Human Services and was named in the 1996 HIPAA legislation as an advisor to HHS, and WEDI does continue to fulfill that role today. As new regulations come about, WEDI provides input to the Secretary on the new regulations that come forward. One of the big advantages of WEDI is that it is a coalition that really focuses on all of the different stakeholders within the healthcare industry. So participants include all the different types of providers, as well as health plans, vendors, government regulators, and other industry stakeholders as well. So the WEDI participants provide collaboration across all of those different stakeholders and really get a variety of perspectives as we look at the different business processes that come up in healthcare. Next slide, please. One of the big benefits of WEDI is looking at providing resources available to payers, providers, all of the different industry stakeholders to better understand and manage health IT. So WEDI really focuses on providing resources like white papers or issue briefs, webinars, articles. As I mentioned, WEDI provides comment letters and testimony for different regulatory opportunities that come up, and it has even provided a HIPAA glossary. So in the Knowledge Center within the WEDI website, there's a very wide variety of resources that are available to help provide education on the use of different ways to understand and manage health IT. So if we look at the next slide, I want to take a look at a couple of the resources that are available specifically around EFT and ERA. And obviously I can't go into a huge amount of detail on these resources, but I want to just focus on a couple that we have and give you an idea of what's included in those resources that you can then go and look at in more detail later. So initially, WEDI formed an e-payments task force to create a document outlining some guiding principles for electronic payments. And this was in 2016. This e-payments task force put together a document that really focused on what are some guiding principles that anyone from either a payer or provider perspective overall should look at in managing electronic payments. So if we go to the next slide, we'll just look at a sample of some of the guiding principles that are included in that document. So again, this document looked at principles that were developed to guide the industry in the use of all e-payment methodologies and help the industry leverage the advantages of administrative simplification opportunities that are associated with the use of the HIPAA-mandated EFT and the ERA standards and operating rules. So a sample of some of the guiding principles that are included in the document include that all industry stakeholders should take the necessary steps to incorporate or optimize the ACH, EFT, and ERA into their workflow, that the EFT enrollment process should be expedited and the current payment method should not be interrupted until the EFT enrollment is completed. Before making any payment via an electronic method other than the HIPAA-mandated ACH EFT, explicit agreement or opt-in must be received from the provider and all fees disclosed, and that the HIPAA-mandated EFT payment must be available with no fees. So again, these are a sample of some of the guiding principles that were developed by this e-payments task force and put forward as best practices for use in the industry. If we go to the next slide, we'll look at a different resource that's available that was created by the Remittance Advice and Payment subwork group. WEDI is comprised of a variety of work groups and subwork groups that focus on business processes for different initiatives within the healthcare industry or business processes around using the administrative transactions that are part of HIPAA. And one of those subwork groups is the Remittance Advice and Payment subwork group. And this work group created a document outlining some of the barriers to adoption and best practices for remediating some of those barriers. This was created, published last fall, and again is available out on the Knowledge Center. If we go to the next slide, again, this is just a sample of what's included in the document, but looking a little bit at the detail. This document started as the result of a 2016 survey that indicated that the industry is still plagued with challenges that result in barriers to adoption of the ERA and EFT transactions. And so in order to discuss these challenges, the subwork group created this white paper and included some best practices for resolving the barriers as well. So some of the items that are included in the document include that some payers don't offer ERA or EFT or don't provide the CAQH core minimum required data for reassociation. Obviously, that's a barrier to adoption of the transactions, but to remediate that, payers should ensure that their systems are updated to provide the ERA and EFT transactions along with the required reassociation information so that providers can move to electronic use of these transactions. Another barrier is that some payers may provide multiple payments per ERA or multiple ERAs per payment. And this does provide challenges for providers, so payers should always create a single payment or EFT with a single ERA and should ensure that the amounts match in both of those transactions. Another barrier that we uncovered is that providers need the ability to automatically compare the reassociation information between the EFT and the ERA, and they don't always have that today. A lot of providers may end up doing this process manually via spreadsheets or other tools. So really the practice management systems that providers use should provide the functionality for comparing that reassociation information automatically and remove the requirement for doing anything via spreadsheet or other manual tools. If we go to the next slide, we'll look at some of the additional topics that are covered in the Barriers to Adoption paper. And this includes interacting with financial institutions, vendors, and clearinghouses, issues around file balancing of the remittance advice, coordination of benefits, using the tax ID versus the NPI in both the ERA and EFT, overpayment recovery, enrollments for both ERA and EFT, processes for researching missing files, determining the plan used in adjudication, and adjustment codes that are used within the remittance advice. So these are all topics that are covered within this Barriers to Adoption paper, with different barriers that are discussed around each of these topics, and then some best practices recommended for remediating those barriers. If we go to the next slide, we can look at some additional resources that are available through WEDI. The Remittance Advice and Payment Subwork Group has created a large number of resources that are available on both topics, both electronic funds transfer and the electronic remittance advice. And all of these are available out in the WEDI Knowledge Center on the WEDI website. So you can see there's information. We just discussed the Barriers to Adoption paper, but there's information specific to how the EFT relates to the 835 and that one-to-one relationship that needs to be there, how to reassociate healthcare payments to the electronic remittance advice, a whole paper talking about overpayment recovery, information on the NACHA operating rules that Priscilla mentioned earlier and how those were updated to include more information for healthcare payments. A lot of detail around the processes for enrolling both EFT and ERA and what the requirements are there from a payer perspective and the needs from a provider perspective. A whole paper on implementing EFT from both a payer perspective and a provider perspective, what's needed to implement EFT, and how to utilize the NPI in the EFT transaction as well. So again, a lot of resources are available out on the WEDI website, and I certainly would encourage you to take advantage of those because they're a lot of very useful information in these documents. And as Priscilla mentioned earlier, we have had some collaboration across multiple organizations within the healthcare industry to consolidate a way to access a lot of these different resources. So organizations like NACHA, WEDI, CORE, even the AMA, collaborated with an organization known as the Healthcare Administrative Technology Association, or HATA, to create a resource library, and here's the link for that, that really gives you kind of a front door into a lot of these different organizations and the resources that are available. So it consolidates access to a lot of the resources that are available for multiple organizations, and it's a great place to go check out for additional resources. If we go to the next slide, we can look at how you can get involved in helping to create some of these resources and giving your input and insight into some of the challenges that happen within the industry or the different business processes that take place. WEDI's Remittance Advice and Payment Subwork Group meets twice a month via conference call, and information is available on the WEDI website for how to join those calls. And there's a lot of other WEDI work groups and subwork groups that are available depending on what your interest is. You can take a look at the WEDI website to see what those are, but for example, we have work groups on telehealth, genomics, different payment models. We also have subwork groups available for looking at the business processes around a lot of the HIPAA transactions like claims or acknowledgments, even a new provider information subwork group. So there's a lot of opportunity to get involved and add your input into what's being compiled for helping the industry use all of these different transactions. In addition, we have WEDI's National Conference that's coming up in May in Scottsdale, and you can take a look on the WEDI website to see what the agenda is for that. But a lot of really good speakers are going to be at the conference. In addition, some of the work groups and subwork groups will be having face-to-face meetings at the conference. So it's a great opportunity to try out some of these different work groups and see where you might have an interest in participating, as well as some great networking and gathering some great information as well. So really encourage you to take advantage of that. And now I'll hand it back to Kira for our next polling question.
Thank you, Pam. So we're going to go ahead and launch our next polling question. So this polling question asks for you to please indicate the extent to which your organization sends or receives remittance advice data using the ASC X12-835 transaction. The options are similar to before, with never 0% of the time, occasionally 1 to 35% of the time, sometimes, which is 36 to 50% of the time, often 51 to 90% of the time, or always 91 to 100% of the time. So again, this is the extent to which your organization sends or receives remittance advice data using the 835 transaction. So we're going to go ahead and leave this open a couple more seconds so everyone has a chance to submit their information. All right, we're going to go ahead and close and share the results of this poll. So again, it looks like the majority of people are using the 835 transaction often or always, and a very small percentage are using it never or only occasionally. For our speakers, do you have any initial thoughts or impressions of these polling results?
Well, this is Pam, and I would echo what Priscilla said earlier about the EFT. I think it's great to see how many providers are using the 835 either often or always. That's very, very encouraging. And then for those that never use it, I would certainly encourage you to take a look at what opportunities you might have for increasing the automation in your office, and potentially speeding up your AR days, just taking advantage of the automation that's there, because there's a lot of opportunity there to reduce your cost and increase your efficiency.
Thank you, Pam. I agree. I think this is really promising, very encouraging. So we are going to move on, and I'm going to send this back to Bob, who's going to talk briefly about Enroll Hub. Bob?
Great, thanks, Kara. And we do just want to highlight a common utility that is available from CAQH, and that is our Enroll Hub feature. It just allows for providers to really supply specific demographic information and assign that information to be retrieved by any health plan that they may submit claims to, and therefore allows them to kind of auto-enroll for EFT and ERA with multiple plans all at once. Again, it does include any of the plans that are participating can access your data, but the provider does highlight which plans they want to have that access granted to. So again, it just is a way for providers to indicate that and to receive EFTs and ERAs from multiple plans all at once. And we do go through, it is very specific. There is a support center if providers have questions. There are ways that the transactions are tested beforehand. And again, each health plan has they've all adopted a similar way to do that, since it's a single utility the providers have to access that information, to provide that information and then grant access to plans. So if you want more information, you can reach out to us on our CAQH website and look at that particular utility if you're more interested in enrolling for EFT and ERA. And with that, I'll hand the call back over to Kira to facilitate our Q&A.
Thank you, Bob. So now we have some time for our questions portion of the webinar. I would like to remind you to please submit your questions by typing them into the questions panel on your dashboard. The first question that we have for our speakers, Pamela, I think this is for you, is what is the best way to handle payer recoupments in the ERA process? Are there any best practices or recommendations?
Sure, thanks, Kira. Yes, the payer recoupments or overpayment recovery is a kind of a hot topic. A lot of work happens around that. And there are processes that are outlined within the 835 Implementation Guide, or TR3, for how to handle overpayment recovery or recoupments within the 835 transaction itself. Recoupments are not handled by the payer taking money directly out of the provider's bank account. Sometimes providers are afraid that might happen and may be reluctant to enroll in EFT because they're afraid a payer may debit their account directly. in order to take back money in the situation of overpayment recovery. And providers can, when they're setting up their bank accounts for EFT, they can prevent that from happening. They can specifically direct that's not allowed. And again, the process for handling an overpayment recovery is specifically outlined within the 835 implementation guide. And then, as I mentioned, the WEDI 835 work group has created a paper talking about how to do overpayment recovery in the 5010 transaction. And then again, in our Barriers to Adoption paper, we touch on overpayment recovery again and how to manage that process using the 835, where funds are taken out of a current check if any recoupment is needed, and then if the current check, current payment, because we're talking about electronic payments, if the current payment is not large enough to cover the entire recoupment that needs to take place, then a balance forward moves forward, and funds might be taken out of a future payment to help satisfy the overall recoupment. But again, that process is outlined explicitly within the 835 implementation guide, and how to do both the recoupment itself within the 835 and any balance forwards that are needed.
Thank you, Pamela, for that great information. So our next question is, what are the biggest challenges to implementing business process changes related to the automated EFT ERA? For example, any staff training, resources, or software?
Well, I can jump in to start, and then Priscilla, if you'd like to jump in as well.
There you go.
I think making sure that your practice management system facilitates handling these electronic transactions is one of the key pieces to making sure that you're successful with this. Making sure that your practice management system can receive the 835 ERA information and get it posted electronically, as well as receiving the reassociation information from the EFT and automatically reassociating those so that you know it's okay to then auto post the 835. Having that process handled automatically is really key to making sure that everything is very efficient and seamless. If we have to do any part of that manually, then obviously there's going to be some retraining of staff that's involved to make sure that they understand the different pieces that are needed and the different manual steps that are there. So again, automating as much of that as possible is where you're going to get the biggest benefit in terms of efficiency and utilization of staff.
Good points, Pamela. And as far as working with your financial institutions, as I mentioned earlier, it is critical that you talk to your financial institution about how they can deliver the TRN reassociation trace number to the provider, and that your staff understands what they need to do. If they're receiving it electronically, do they have to log into a system at the bank, download that information, or is that information pushed to the provider? Is it something that you pull off your electronic bank statement? There are a variety of ways that the banks can deliver it, and it really needs to be tailored to what the provider can actually utilize. And so having your staff understand, or making sure they talk to the bank first, find out what the options are, and make sure that they do download that information or get that information, because as Pam pointed out, the real value to a provider is being able to receive the payment electronically, the remittance electronically, and doing an auto reconciliation and auto post. That's going to really make the biggest impact to your to your organization, and allow your staff to be freed up to help your patients instead of doing the back office transactions. So making sure your practice management system has the auto reconciliation capability. Make sure you talk to your financial institution so that you get that information from them with the payment information, and that they do understand how to auto reconcile and how to post.
And I'll just jump in again and point out to have the conversation that Priscilla is talking about with your financial institution. There are some resources available to help with that. Bob mentioned earlier some core resources that are available to have that conversation with your financial institution. And the WEDI papers that I mentioned earlier also have some specific language that you can use in having those conversations with your financial institution to make sure that they understand exactly what you're asking for and to help make that conversation go more smoothly.
Thank you both for that wonderful information and resources. I think it's going to be really helpful for folks. Our next question is for Bob, and it's regarding Enroll Hub. What is the cost for providers to use Enroll Hub?
Oh, great question. I'm sorry I failed to mention that. It is free for providers to use. So there's a free utility, web-based, where providers, again, can enter in specific demographic information to allow themselves to enroll for EFT and ERA with multiple health plans all at one time. So again, it is free for providers to use.
Wonderful. Thank you, Bob. So our last question for our speakers is regarding someone who is wanting to change and transition into using electronic funds transfers, but is having some difficulty with charges for EFT. Is there anything that they can do to get the payments via EFT without being charged a fee?
Yeah, I can jump in and answer it. I'm sure Priscilla has some comments as well. Excuse me. The HIPAA mandated EFT transaction is required to be provided if a provider requests it. So any other form of electronic payment or paper check is not what's included in that requirement. If the provider asks for the EFT via ACH, then the health plan has to provide that. And according to the HIPAA regulation, it has to be provided at no cost other than the standard transmission type cost, which is extremely minimal, typically what you would see through your bank, just a few cents. So if a provider is encountering a situation where there's potentially a fee, then I certainly would push back on that, make sure that they're evaluating any contracts that they're being presented with to make sure they're not being asked to use some other value-add service like a portal or something that might be causing some additional cost to be incurred. So continue to push back against that cost and ultimately use the HIPAA asset tool, the CMS asset tool, which is the mechanism that can be used to file a HIPAA complaint. If an entity continues to pursue a fee for an EFT transaction, then I would ultimately go through that process of using the asset tool to document that information with CMS, which would then initiate some dialogue to help remediate the situation.
Wonderful. Thank you so much for that really helpful information. We are unfortunately out of time today, but I want to say thank you to our wonderful speakers for joining us, and thank you to everyone on the call for attending today. Here we have some information about our next few scheduled webinars and education events. So thank you for joining us. If you have absolutely any questions, maybe we didn't get to your question today, or if you have questions about upcoming events and webinars, please feel free to reach out and email us at core@caqh.org for more information. Thank you all and have a great rest of your day.